name is Andy Garrett. I'm a EMS physician and a pediatrician. Been at GW for about 6 months after about a 10-year career with the United States government at the Department of Health and Human Services, where I oversaw the department that is in charge of civilian disaster response for the United States. There's about 100 teams that provide medical support to communities that are affected by disaster. It's called the National Disaster Medical System. So I was director for that program, and prior to that, I was the Deputy Chief Medical Officer. Before that, I've had a smattering of jobs through medicine and healthcare, but all of them related in one way or another to pediatrics or pre-hospital care. I also worked for the public health school at Columbia University in the National Center for Disaster Preparedness, which really cemented my love of EMS and disaster medicine together, and the rest is history. If you want to go way back, it starts when I was a kid in the 70s. Just like many people in my generation who started in EMS, I was influenced by television, the show Emergency, which really did lead to the development of the first wave of EMS in the United States. EMS is a relatively new thing. Really, it was only a concept in the late 1960s. So I was in pretty early, like in the 70s, being really interested in the television show, and started watching fire trucks when I was 15 and became an EMT as an undergraduate at my college in a course I helped to organize. And ever since then, I've been involved in EMS or pre-hospital care in one way or another. I was a U.S. Park Ranger for 6 years out in Yellowstone Park. Law enforcement, fire services, park medic, delivering advanced life support care to the huge number of visitors that come through there. And then starting with medical education, I started about 4 years later than most, but my journey really took me through the traditional learning of undergraduate college, and then 4 years of medical school and 3 years of residency, and then I did a 2-year fellowship specifically in EMS and disaster medicine. I was able to get my public health degree during those 2 years. And really that's where I formalized my interest, my education, my background in being a doctor who's really committed to overseeing EMS systems and making them better. And that definitely influenced my choice of careers as a flight medicine, as a public health person, as a government guy, and now as an educator. When I come here to as I've come here to GW, I'm really interested in training up the next generation of people who are going to walk this journey too. And it's far more interesting when it's not a straight line. "20 years represents about half of the lifespan of EMS in the United States. EMS, like I said, really wasn't a thing before around 1970. So it's so fascinating to be part of a specialty of medicine that is really in its adolescent growth curve. So it's interesting because we don't know the right answers to a lot of what we do. You ask what's changed. A lot of what we did in EMS over the last 25, 30 years is what we did in other emergency services like the fire service or law enforcement, because again, we're learning how to do this right. And it's such an exciting time to be involved in EMS as an EMT, as a paramedic, as an EMS physician, or as a mid-level or nurse practitioner or physician's assistant. There's roles for all kinds of people in EMS right now, including public health and people who do statistics and bench science. So much is happening right now that we need really dedicated, smart people to continue to carry this torch. For example, look at some of the programs just in the last 10 years. So 2010, some of the out-of-hospital cardiac arrest survival rates were only 5 or 6%. Now in some departments and some jurisdictions, they're seeing upwards of 50+%. And all that's happened in the last 10 years because of the ability to leverage EMS's role as not just an emergency service, the lights and sirens business, but also part of healthcare and also part of public health. And EMS really sits at the intersection of those three. And when you pull the strengths of all of those, you can really do amazing things. And again, this is just the start. We're seeing phenomenal increases in how we engage the public to help save lives out in the field. EMS is an important part of the link to getting people from where they have a medical emergency to hopefully walking out of the hospital. But there's a huge public health component of this too. There's an EMS public health component where you're teaching people CPR, you're getting people early access to defibrillators, you're getting the right resources to the person at the right time, you're working closely with the emergency medical dispatch to make sure the advice that's coming over the telephone is validated and in a good situation to help a bystander save the person's life for the person that maybe had a heart attack and is lying on the ground next to you. Everybody has a role to play in that link. And when the link all works together, all the way up to coming to the hospital and potentially going to the catheterization lab, we're seeing the number of people walking out of the hospital after an out-of-hospital cardiac arrest. Like I said, the numbers are going up quickly, and it's just an exciting time to be part. I just talked about cardiac arrest, but These have the same discussion for things like stroke and sepsis. There's all kinds of stuff happening now. It's just an exciting time as we're sort of in logarithmic growth of the knowledge of EMS. I think what we're going to see is a continuation of the engagement of EMS, not just as a separate pre-hospital component of healthcare, but as part of a constellation of healthcare. And we're starting to see that now. I mentioned this is an exciting time. The way the federal government pays EMS people back for doing the work they do has radically changed in the last couple of weeks. The Center for Medicaid and Medicare Services is doing a pilot that's going to go for 5 years, looking at how can we do a better job in EMS, not just stuck in the dogma of taking a patient to the hospital because that's the only thing they're going to pay for, but now how can we get the right resources to the right person, either when they call 911 through maybe a nurse or another medical triage line that can give somebody medical advice and get them to the hospital some other way than taking an ambulance. Or maybe EMS can be reimbursed for taking a patient to a destination that's not necessarily an emergency room. ERs are overcrowded. They have been for decades. The more people we can get to the right care at the right time, that's how we take better care of the population. And EMS is such an important part of that. And it involves not just EMTs and paramedics, but like I said, EMS physicians, mid-levels, dispatch, law enforcement, public health, senior services, veteran services, all that comes together, and EMS is going to be an important part of this constellation of healthcare services. So this concept of being part of community paramedicine or community health is really where it's going, I think, in the next 10, 20 years.